So quickly, I wanted to talk about breast cancer. Now, my interest in breast cancer for you today is only at the time of first relapse. After the surgeon, with help with adjuvant treatment, maybe neoadjuvant treatment, has been unable to cure the disease. And we all know that any breast cancer, whether it's ER positive, HER2 positive, or triple negative, if it relapses after primary therapy and the patient is healthy and will live a long time, is likely to be the cause of the patient's death. Sometimes it takes many, many years. Sometimes it's fulminant. So that's what I wanted to talk about. I'm talking about my dear friend Chuck Peru in 2000 with the team from Stanford, and then and Ultimate Sites came up with the molecular portraits. And we've been talking about luminal A, luminal B, HER2 positive, normal, and basaloid for a while. But that's primary disease. That's the classification when it starts. I'm not interested in that. My role is to try to help patients who didn't get cured or who present with stage 4 disease to get a longer life and to live with their disease and to change it from fulminant, acute, and fatal to long and chronic and able to live with it. So I've reclassified in my own mind, and I'm going to show it to you in a schematic better, the molecular characteristics of recurrent breast cancer. And that's what my presentation is about. These different classifications based on, in this first one, 8,600 plus cases involving the HER2 pathway, the hormone receptor pathway, the homologous recombination defect and a DNA repair pathway, the immuno-oncology sensitive, the PI3 kinase mTOR pathway altered, which is of course the major category here, the FGFR, which is under-recognized and very important, the cell cycle. I wish we had better drugs, but we do have an approved one and a second approved one, so the cell cycle inhibitors, and then finally the rarely detected but important other kinases like BRAF and KIT and MET that all can play a role in putting a breast cancer patient who's relapsed on a precision personalized therapy. So let's start at the beginning, and I'll digress now and say my role here is the principal investigator and co-patent holder of the FISH test for HER2 gene amplification in breast cancer. And I loved my FISH test until I started doing hybrid capture-based comprehensive genomic profiling. This is the first patient ever tested at Foundation Medicine. I brought it over in my pocket, 2 blocks, one from the tumor, one from a benign area in another outer quadrant. I wanted to see whether this test, which was the first to try Illumina on formalin and paraffin embedded, and see whether they could detect the same 18 copies of the HER2 gene that I had detected by FISH on this patient. And when they came back to me with the result, they said, "We find that your sample is HER2 amplified and has 16 copies of HER2. Well, it's right on the nose. I was thrilled. It works. And then they said, and we also see the same 16 copies in the other block you brought. I said, oh, this doesn't work. HER2 amplification, that doesn't occur in benign fibroadipose and a little bit of breast duct tissue. What's wrong? You're not supposed to see HER2 in benign. And I thought and finally did the one thing pathologists are always reminded to do, go back and look at the slides. So I went back and looked at the slides, and my resident had contaminated the benign block from the outer quadrant by not cleaning their knife, and a piece of the tumor was up in an outer corner of the block, had gotten extracted along with the benign tissue, and the test was so sensitive it picked up HER2 amplification in that tiny little piece of tissue. And I walked back in and I said, it does work. So here's what we did with that case. We showed that it had multiple, I don't know where the pointer went, so I'll try to use the mouse, but it's not here on the table anymore. You can see down here in the corner here that the FISH, maybe you can see the cluster and amplification, the 3+ IHC staining, and here the copy number plot, and look at the copies of HER2, right up there by the chromosome 17. But notice that there's something else next to it, which is RARA, the retinoic acid receptor, which is the most common co-amplified gene with HER2 in breast cancer. When we have a HER2 amplified patient, maybe presents with metastatic disease or recurs after adjuvant anti-HER2 therapy and has a RARA coamp, should we try to target this? I mean, ATRA probably wouldn't work because that's after a RARA fusion, right, in acute promyelocytic leukemia. But there are other RARA drugs. I never used to know with just FISH that there was another gene co-amplified. Sometimes it's topoisomerase 2 alpha. And then there's a whole subset of about 60% of them that have no other genes co-amplified. Are they biologically different than the ones that do? This is what I mean about precision and getting more information than just do a HER2 FISH test or stain it for HER2 expression. When you do the comprehensive profiling, you get to find out a lot more information that someday may be really critical for helping these HER2 positive patients. I did this study very early. I made the observation that when you had E-cadherin mutation and a lobular histology, and the patient had relapsed, and remember these are all ER positive, they had a high frequency, over 20 and almost 30% with a sequence mutation in the HER2 gene. Now this is going to not have a positive FISH, it's not a copy number story, or a positive IHC, there's no increased protein production. But there's either a kinase domain activating mutation or an extracellular domain mutation like S310F or Y that's causing hyperdimerization with HER3, and then HER3 dimers are signaling back and turning on the HER2 intranuclear signaling. Well, can we target this? And of course, we've learned that we can, and we can have significant benefit in a subset of HER2 negative by standard slide-based testing, but HER2 positive by comprehensive genomic profiling patients. And here's an example of that, a case of a woman who was in hospice, had given up. She had terrible triple-negative inflammatory breast cancer with very debilitating changes in her skin, neck, shoulder, arm, and chest, as well as mediastinal massive disease. She was offered getting this genome sequencing test. This is way back in 2012. We sequenced her, and she had two different HER2 mutations, the V777L, which is the kinase domain mutation, and an S310F, an extracellular domain mutation. The drugs that we had at the time were limited. She got lapatinib and capecitabine and got an amazing response. You can see how much her skin is improved on the two panels here. I'm going to not try to use the mouse anymore. You can see that on the left, and she got substantial PET-CT benefit. This lasted a little under 9 months, and then she did relapse and die of her disease, but she told us when she started to relapse that she had gotten to plant her garden again and harvest it, which was so important to her, rather than stay in hospice on no therapy and die with only supportive care. So this gave us a glimpse that you can learn things. Here's a second case of a HER2 sequence mutation. This is published in the Journal of the National Cancer Comprehensive Network that we published of a patient who got dramatic benefit targeting ERBB2 or HER2 without amplification and with negative findings. So I asked myself the question, is a triple negative breast cancer with a HER2 mutation really triple negative? Does that move the patient back into the HER2 positive or not? We've got one classification that's looking at phenotype and another one that's looking at genotype. So here's a second case study of showing what you can do with this, and again in the HER2 group. This woman had classic, highly amplified HER2 positive metastatic breast cancer. FISH and IHC clearly positive. She was placed on single agent trastuzumab plus chemotherapy backbone, the classic treatment for this disease, with no response whatsoever. It really confused the oncologists, so they sent the case in for Foundation 1 testing, and we found a classic lung cancer alteration, the L858R base substitution in exon 18 of EGFR, a lung cancer alteration in a breast cancer patient. In the US, there's obviously no approval of erlotinib in the treatment of breast cancer. We went to the payer, asked for permission. The payer said, okay, 90 days you could try erlotinib, add it to the trastuzumab. We did that, and she went into complete response rapidly. And we published her. So we thought that in this case, a rare EGFR activating mutation was a resistance mutation to anti-HER2 therapy in a HER2 positive patient. I didn't think it was wise to say it was a HER2 amplification as a resistance mutation in an EGFR positive patient, because this was breast cancer, not lung cancer. And here is some of the publications showing the benefit of the adding of the EGFR TKI to the anti-HER2 antibody. Here's another example of where sequencing can help, and I put this in because we've been talking about NTRK today. And this is the classic secretory carcinoma of the breast. It's very rare. It usually does not metastasize and behave aggressively, but occasionally it does. This case came into us as a primary lung adenocarcinoma. We sequenced it and found a classic ETV6 NTRK3 fusion, characteristic of either salivary gland adenocarcinoma or breast secretory carcinoma. Turned out to be breast, and this patient has done beautifully on an NTRK inhibitor. What about triple negative breast cancer? There's so many possible ways to go with therapy on this, because if you sequence them, you don't know what you're going to find until the results come in. You may find all sorts of different kinases you could try to exploit. You may be locked in with only, the PI3 kinase mTOR pathway, which is a little troublesome to get really long, sustainable responses. You may have cell cycle alterations like the CDK4/6 or the cyclin D1 amplification and target it with a cell cycle drug, or go after the kinases. And the one that's exciting to us now is BRAF. We seem to be seeing good responses in triple negative driven by BRAF. It's only about 3-4% at the most of triple negative, but when you find it, it's really worth trying to target it. And I'll talk a little bit about that as we go on. MET-AMP, again, 2 or 3%, maybe a MET targeted therapy. We even have KIT positive with the imatinib sensitive mutations in triple negative. Very rare, that's a 1%er at all. So here's a case of triple negative breast cancer with a BRAF alteration. And this case was presented by my good friend and colleague, Joan Albanel from Hospital del Mar in Barcelona, in which we showed the presence of the BRAF mutation, and this patient got significant benefit from anti-BRAF targeted therapy. So I want to switch now over to the liquid biopsy. Obviously, Foundation does market one called FACT, and FACT with tumor mutational burden is due to be released later this year. It has a different gene set than Foundation 1, far fewer genes, only 61, and we're going to add ATM very soon. I think it's actually already been done and released. And this is, of course, because in order to do this right, the coverage depth has to be extremely high, not below 5,000x. Each new gene you add increases the cost of the test so significantly that it becomes commercially unavailable. So we have to limit what genes we can put into it, but we are able to calculate the tumor mutational burden from it, and we're also able to determine, we believe soon, the microsatellite instability high status out of it. But the main use of it, when it was designed, was for patients who couldn't give a sample due to risk or availability. There was nothing in the laboratory. There was no more formalin fixed paraffin embedded, and the only way you could get any kind of genomic information was from blood. Or the patient was on a known targeted agent, and this was a good test to look for resistance mutations. We already know from the story of osimertinib using a digital droplet PCR method, not this Illumina hybrid capture method, that 70% of the patients on an TKI with EGFR-driven lung cancer who develop resistance, and that resistance is due to the T790M alteration, 70% of the time it can be picked up in blood, and you don't need a metastasis biopsy, saving the patients the cost and the risk of having to undergo that, and you only have to biopsy if the blood test is negative. Well, with that all said, so these are the main uses. I have found that I believe for breast cancer, it may be better to start out with this rather than a tissue metastasis biopsy. First of all, some patients have multiple sites, and if brain is involved, we have good evidence, both experimental and in the clinical literature, that brain metastases may be unique in their genomic signatures compared to bone and compared to lung and liver and other visceral sites. And the only way to get at them is by pooling all of the alterations in blood and detecting them in a very sensitive 5,000x coverage liquid biopsy. This test has had robust analytic validation. The analytic validation paper, the manuscript is due out any day, so to speak, and this will show how the test is done, how the positive and negative control systems are done to completely prevent false positive calls. We don't make mistakes on copy number and issue false copy number amplification results. And we feel our sensitivity is as good as it can be. And when we don't find alterations, it's because either there's absolutely no tumor DNA in circulation, or the amount is way too little for any test to be able to be accurate when it tries to sequence it. For breast, the ctDNA assay, we've published this. It's in a couple of months ago in the ESMO journal in Annals of Oncology that showed how easily we can pick up the ESR1 mutation, which is by far the most common cause of failing the patient with the hormonal therapy, usually after transition to aromatase inhibitors. When the tumor relapses on that setting, it's usually an ESR1 mutation. But if you compare the blood tests, whether it's RFAC test, whether it's digital droplet PCR or other NGS blood tests, they all outperform biopsy of metastasis based. The biopsy of metastasis will yield an ESR1 mutation in the 25 to 30% frequency, maybe 35%. All of the published studies, including ours, go way over 50% when you use blood to find the ESR1 mutation rather than tissue. And this study shows that you just don't find the mutation, you can define the mutation in detail, as you know. There are many different kinds of ESR1 mutations. The blood test will find them all. And this will help greatly in deciding therapy. It's a regular blood test, as you know. It's catching on, but there are indications where it is much more useful, and I think breast cancer is one of them. And the amount of impact on the HER2 versus non-HER2, ER positive versus non-ER positive, and triple negative are all substantial. So let me go on to that. We do obviously BRCA1 and 2 sequencing both in the blood and in the tissue, because firstly it's important for our indication of the PARP inhibitor use when tumoral BRCA1 or 2 are mutated. This may or may not be accompanied by a germline mutation. But now we have to expand to be able to use our technology to get at some more late-stage serous ovarian cancers, breast cancers, usually triple negatives, and prostate cancers that have enough homologous recombination defect and DNA repair defect that they also might benefit from PARP inhibitors. In our experience, which is pretty limited right now to ovarian cancer, it's true that none of these other indications will outperform BRCA1 or 2 mutation in terms of the PARP inhibitor efficacy. But the efficacy seems to be good enough in the BRCA1 and 2 wild type, whether it's prostate or whether it's breast or ovary, to still want to consider PARP inhibitor therapy when the HRD score, or so-called loss of heterozygosity, will indicate that. And that's where we're going with it now. We're waiting for an FDA approval for rucaparib for our HRD score in serous ovarian cancer. We're also working on it with multiple pharmaceutical companies that make PARP inhibitors in triple-negative breast cancer and in castrate-resistant progressive prostate cancer. Now, we can also determine TNB in metastatic breast cancer. We don't know yet how to correlate the height of the TNB alteration with the responsiveness to checkpoint inhibitors. But we know that there's a subset of triple-negative breast cancer, maybe it's 10, maybe it's up to 15%, that respond. And we want to find them by testing, and we think TNB shows great promise to do that. There's some good correlation between TNB and the expression of PD-L1 in triple-negative breast cancer. So here's my summary and final slide. It's using the liquid biopsy to make treatment decisions on the time of first relapse in breast cancer. And I've divided it into what I consider the 3 categories: ER-positive breast cancer, HER2 positive breast cancer, which may or may not be ER positive also, and triple negative. For the ER positives, the ESR1 mutation dominates. As soon as that's detected, the patient needs to be switched immediately to a SERD, to a degradatory drug. Fulvestrant is the current available one. Others in trials look like they're more potent. We want to try to get control of a hormonal status with a different approach, since constitutive activation occurs when ESR1 is mutated. But we may find a PI3 kinase mTOR pathway alteration and try an mTOR inhibitor or a PI3 kinase inhibitor, if we can get one, a really really works well. We may find cell cycle alterations that really drive to use drugs like palbociclib, or we may find one of those HER2 mutations that you didn't see on the upfront testing on slide-based FISH and IHC, but is driving the tumor and would respond to an anti-HER2 drug. For the HER2 positives, what's caused the HER2 therapy to fail? Is it a PI3 kinase, mTOR pathway storyline, which is the most frequent by far? Well, then we try to go and target that. If it's MET amplification, which is in second place as a cause of HER2 resistance in HER2 positive treated cases, then we might add a MET inhibitor. And we have seen other kinase inhibitors like that EGFR L858R one that I showed as an illustrative case. And finally, on to the triple negative group, where at the time of first relapse on chemotherapy, sequencing can get the patient transitioned over to targeted therapy. And that could be, as I mentioned, a BRCA mutation that could lead to PARP inhibitors. It could be a HER2 mutation again that could lead to HER2 inhibitors. It could be another kinase mutation like EGFR, which is rare, or BRAF, which is more common, or FGFR, usually 3, or some of the others, KIT and MET. And then finally, the high TNB. We don't know what the cutoff should be for triple negative. Should it be 15? Should it be 14, 13, rather than 20 in order to get more patients on an immunotherapy protocol? We don't know yet, but we certainly think there's a major subset of triple negative that need to be tested and driven right into immunotherapy as soon as they relapse on the chemo regimen that they had received in their adjuvant treatment. So in application of comprehensive profiling to metastatic breast cancer has emerged for relapsed and refractory disease. This can confirm HER2 status of the primary disease. It can explain the resistance to hormonal anti-HER2 and triple negative chemotherapy. And personalized approaches to the treatment of clinically advanced breast cancer show great promise to add months and possibly years of survival as treatment regimens are customized according to the exact genomic drivers of each patient one at a time and applied to the care of that patient right at the time of first relapse and not held off while second line and third line chemotherapy regimens are tried. Thanks very much.